Hello, good morning.
Yeah, Sudhir and Dr. Yamane, please have the case and show the
Good
case
morning,
first.
Pratap. Good
Yeah,
morning.
please.
Good morning, everyone at the auditorium. So let me present the case first. I've seen the slide for the first time. So could you bring on the slide, please? Okay, so we've got a cracking case here, a 49-year-old gentleman who has got a risk factors of hypertension and presented with angina on exertion for 2 months. And then he was admitted in April this year with acute coronary syndrome, and ECG showed some T-wave inversion in inferior leads, and echocardiogram showed normal LV function. Coronary angiogram was done at that time. I'm not sure whether we can show that angiogram or not, but what it showed is there was a 3-vessel disease. There was a chronic total occlusion of the mid-left anterior descending coronary artery after a diagonal branch, and there was a severe disease in the proximal left circumflex, and right coronary artery was also having proximal severe disease.
Yeah, just Ben, I understand.
And then this gentleman, after that, his syntax score came out to be 23.5. EGFR was normal, and it was decided in the setting of acute coronary syndrome. He underwent angioplasty to right coronary artery and left circumflex coronary artery.
Okay, sir, you are getting better.
A couple of weeks back. And then this morning, we have target vessel is left anterior descending coronary artery, CTO. So he's already had a stented right and left circumflex coronary artery, and we can show you the pictures from this morning which we have taken. If you can go back to the first picture. By the time they go to the first picture, what we have, I've got Professor Yamane by the side of me, and you've got a great team here. And setup is bifemoral 7 French long sheath, and you've got both 7 French guiding catheter, EBU 3.5 to the left coronary system, and short implants with side hole to the right coronary system. So you can you see the first picture?
Yeah.
So you can see the first picture here, LAO, simultaneous bilateral angiogram on 1 magnification.
Okay, after that, I'll take over because I selected the guiding catheter. The left side is a short implant 1.0 side hole, and the left side is a 3.5 side hole, EBU for the 7 French. And as you can see, today's target, since the last time they actually treated the critical stenosis of the RCA, now that the collateral from the distal PDA coming back to the distal LAD as well. So not only the epicardial collateral from the diagonal of the circumflex, we have several sources of the distal LAD. Nonetheless, the proximal cap of the LAD is very much eccentric at the junction of the diagonal branch. So what we try to do is just for the discussion as well as live sake, probably we put the guide wire to the diagonal branch and to confirm the proximal cap. During the preparation of this case, we just go through the some IVUS, Boston IVUS, to show that the proximal cap. So could you go around the professor? This is a Boston IVUS opticross, and basically that whether you use a mechanical IVUS or that the phase array system, probably it's a matter of getting used to. So when you really get used to the image of each IVUS, Boston has a very much high resolution image. Probably you can just locate it where the proximal cap is. So the cap is supposed to come from the almost 7 to 9 o'clock. And this is probably LAD, which typically a little bit flow down there. That means that the some not straight proximal portion as well. So in this case, this is a very good landmark, and the cutting surface of the LAD does not have severe calcification. So that is a point we have reached so far. Is there any question or comment?
Actually, we wanted to understand what is the approach to the case, whether can we try an antegrade approach, or I think antegrade is we should try first, then
Yes,
we have to think about septal collaterals are there and epicardial collaterals are there. I think first First of all, we have to try an antegrade approach because you have a, definitely at the lesion it's at the bifurcation. So you can try with a Crusade or Sasuke catheter and then try
Or you can do an IVUS guided
Puncture.
antegrade puncture.
That
You
will
can
be-
show us an IVUS guided antegrade puncture.
that will
Yes,
be
so that
happy
was
for
the-
us. If you can do that, that will be the best thing for us.
Okay, so yeah, so that was also, we discussed about it in terms of approach. So our first approach will be antegrade wire escalation. We did the IVUS to identify proximal cap, and Dr. Yamane very skillfully now trying to advance the IVUS catheter. As you can see, can you see the angiogram picture now?
Yeah, we
Yeah,
can.
angiogram.
So,
we can s-
can we just see more? So I think there's a wire looping in the aorta. What we have got slight technical is that we have got a 7 French system, and we have got a live intravascular ultrasound in the diagonal branch, and we have got caravel, caravel with a with an antegrade wire.
I think your catheter, caravel is backing up. What is happening?
I think
It's
that is,
looped,
that
yeah.
is the
Looped,
IVUS,
okay.
which is IVUS buckling.
IVUS
I think
IVUS is looped.
both IVUS and caravel at the same time simultaneously are having a little bit of a problem via the 7 French system, it looks like.
Yeah, I think numerically probably 7 French.
Is okay.
IVUS as a caliber is okay, but practically speaking, it's very much resistance today. So I'm something a little bit wrong, but I think it's quite okay to use. Yeah,
Let me see.
yeah, but
Yeah, so looking at the cap and looking at the angiogram pictures, we couldn't see any, so we decided to go with a Gaia 2 next. So the wire here is Gaia next 2 with a caravel backup.
You have an IVUS live image is there?
Yes.
Can
No,
you
no.
show that also in one of the corner?
Yes, we will show you. We are just trying to place the wire. Can we go
yeah,
live
but
on the
a
IVUS?
little bit practical problem is that when we advance both gears, actually the patient has a complaining chest pain, so he is very much sensitive. But of course that we understand. But that is the IVUS here.
Yeah.
Yeah, yeah.
So you're, why is it 7 o'clock?
Could you pull back the IVUS?
8 o'clock?
Yeah, start pulling back.
Sudhir, IVUS is actually in the, that vessel is in the 8 to
o'clock
9.
was-
Now it
Vessel
is
of what?
totally not seen.
Yeah, I think the wire, IVUS has not crossed the bifurcation point. It's in the proximal LAD. So we're trying to reposition the IVUS.
Okay, but that's. I think a shaft of the IVUS is a
I
little
think
bit
what we
different.
are problem having is it's difficult to maneuver both the IVUS and the microcatheter at the same time. And patient starts having chest pain. So Dr. Yamane is again trying to do that, but we are removing the IVUS now. and
Sudhir, we another 1.5 minutes. We have to go to the next lab. Actually, we show. Then we will.
Yeah, and
Okay, so
somebody
you've
could
seen-
just adjust Dr. Rathore's acoustics because his voice is not coming out very clearly.
Sure.
so-
So after puncturing, probably we'll show you the IVUS later time.
Actually, we
Please,
were hoping
please.
to see the IVUS guided puncture and learn from you.
Yeah,
That's
thank
what
you.
we were trying to do. This is slight technical in terms of
We can switch over to 8 French catheter then.
Would it be appropriate to switch to an 8 French
French-
guide?
Yeah.
8 French guy.
guide.
By that time, we will come back from the other lab.
Yes.
Okay.
Okay, we
Thank you.
can do that, yes.
Can we
But
move
this
on
is
to
a
the lab of Hiranandani? Mr. Ujjwal, can we go to Hiranandani?
I think it's crossed.
He's already
Yeah,
crossed.
I think it's
yes.
crossed.
I think we've got a fair idea. We wanted to just see that the
See,
proximal,
one-
the
one
wire
minute.
is in the center of the
30 seconds.
occluded segment. But I think we will see, we'll take some retrograde pictures and see the position
yeah,
of
please,
our wire
please,
and
yeah,
we'll come back
please.
to you.
Okay. Yeah.
Okay.
Right side injection. Yeah, please.
Okay. So we will take some, let me just see.
Sorry.
Okay, some right picture now.
Close.
So we are very close, as you
Close,
can see.
close.
You're near the
Close to-
distal cap now.
Yeah, we will do some pictures. We will
I
progress.
think, Sudhir, anyway, we have to go to the other lab, but.
Okay, you go
exact-
to the other lab and
We'll
come
go,
back
but,
and we'll save
you sh-
pictures for you. We will try with the antegrade wire escalation,
Sure.
secure the position
You
and then...
try and keep all the images for us.
Yes.
Okay. We'll go to the next lab. Sudhir, we are back with you. Sudhir.
Okay, yes, yes.
Yeah,
Orthogonal
Hello?
projections. Yeah.
Yeah, three pictures back. Actually, I believe that we puncture the proximal cap. This is the guy next to 2, and you can see that the very much faint distal collaterals over the bifurcation. So we try to check with another new wire, guy next 3, because the tip needs to be more straighter and a shorter curve. Next. But the cranial projection does not show that the good progression. The tip is apparently outside.
So
And
out to the
next,
vessel.
so that the Sudhir suggested a very nice idea that the de-escalation. So in this case, the guy next 3 tip actually rotating back and forth, and there must be something very stiff for one over the triply one is existing at the proximal distal cap. So in this case, we just use the XDR next. So now we are moving the XDR tapering wire here. In this projection, just in line with the distal vessel, still there is a gap. And we go to the RU.
It is a wire is XTR, right?
Wire is fit XDR, yes, yes.
With a fine cross microcatheter.
With a caravel.
The microcatheter is a caravel.
Caravel,
actually.
caravel,
Yeah.
okay.
Caravel has a more support. So we take a picture, and if that is outside, we switch to the retrograde from the RCA. Please.
Okay.
Yeah, I'm afraid that the number
Still-
one is distal visualization is more distant. So that means the antegrade wiring is just pushing something outside of the true lumen. So
Right.
in this case, it's better to have a little bit more earlier change for the retrograde.
Dr. Yamane, you would like to go retrograde, or would you like to do a parallel wire here?
Parallel wire?
Yes.
Yeah, I could have do the parallel wire, but since 7 French and I was
You can actually get the, because now the IVUS is not really helping you, you can get that out and you can try a parallel wire even with a 7 French.
No, actually, I will be changing over to a Gaia second or Gaia third wire instead of a XTR.
No, he de-escalated.
No, it is accelerated only to XTR, still XTR.
coming in.
Will you not change over to Gaia second or Gaia third now?
Just a second.
Yes,
Yamane?
we could.
Huh?
Will you not change over to Gaia third or Gaia second now?
No, because even the feeder XCR goes to the different layer, so that means stiffness is not a matter. There is some complex plaque over there. So probably we need the, either the parallel wire technique or the some
Yeah.
retrograde. But among the choices, even with the parallel
So
wire
when would you
technique,
try a parallel wire and when would you like to go retrograde straight away?
I'll go the straight right away.
Okay.
Okay.
Because
Caravel
Dr.
one.
Werner
So
is
we will
here
go to-
and we would really like Dr. Werner's view whether he would like to do a parallel wire or he would like to go retrograde.
No. It's not one or two choices. It depends on the case.
Any choice can be taken. I
No,
don't
no,
think
when-
you will
when
do
you
a...
see when you see the distal vessel is not poorly visualized by advancing the guide wire, probably you may lose any chance for the either the parallel wire or the IVUS navigation, because now we are getting the hematoma larger. So that
Okay.
means the best way is just not
Go
for
retrograde.
yeah
Okay.
doing that.
That means you will never go for a escalation now. You just go to a
Dr. Werner, sir?
Werner, you will be going for escalation, parallel wire, or retrograde.
Oh, truly, we are not questioning that.
He can do anything, but we have for a discussion.
Yeah, also in this case, we have attempted.
With a parallel wire. Yeah.
Do that. But if the parallel wire fails again, we have to
go
go
back.
back to
Yeah, then
the,
you have to
retrograde.
go retrograde.
Yeah, the other thing is the distal tip of the anti-grade wire is little bit far from and the distal cap is not very well visualized. The filling is not good, so
Yeah,
we will have the same problem when we do the
Elio?
parallel
Elio,
wire,
please.
because you need to have a good visualization of the distal cap.
Sudhir,
so
Sudhir,
syringe
personally,
control, right?
I will withdraw the microcatheter
Yeah, I would
and
also withdraw.
re-puncture the vessel
Yes.
with a high-grade wire or Gaia third or a Miracle 6 at
Elio, please.
little
Elio,
proximal
please.
and then do it. We'll try for that.
Yeah, of course, we'll see if he's got a good interventional collateral from the right coronary artery.
No doubt.
So in terms of moving down the decision tree and keeping the efficiency as well, I think it might be more predictable to get better position from the from the retrograde. If obviously if there's any difficulty, we'll come
Sudhir,
back.
but globally,
to
I mean,
position.
you're here, you all are very experienced and masters. We have a master sensei who's doing this, but many of us have reticence about going retrograde. And possibly by seeing how comfortably Dr. Yamane would be able to do it, we would increase our confidence, but most people would probably try a parallel wire first. At least that's, in the opinion of the house, I mean, how many people would try a parallel, how many would?
Parallel wire is actually, I think, escalation, how many people will do? Withdraw the catheter
Nagamori?
escalation. I think
Dr.
most of the
Mr.
people will try
Nagamori,
that.
syringe?
And second
Syringe?
choice is parallel wire, third
Syringe.
choice. I
Syringe,
will
syringe.
do escalation.
Medaillon,
If fail, I will go to retrograde. I don't do a parallel
we
wire.
have a special syringe.
But you presented parallel wire technique
Because
yesterday,
actually-
Pratap. You presented very elegant cases on
The
parallel,
parallel wire
technique.
basic issue is actually you create a lot of subintimal.
Different thing. Now,
dissection
for
will be much
discussion's sake as well, some people think a parallel wire as some kind of a re-entry technique, which it is not, in my view. Because sometimes what happens in parallel wire, what we are trying to achieve is where the wire has gone, try to get some idea where the wire has gone subintimal and try to gain the true lumen quite proximal rather than where the distal wire appears in terms of parallel wire to get into the true lumen with the guidance of the first wire which is in the subintimal space. Because it's difficult to get into the subintimal much beyond the proximal cap or long into the subintimal segment and then try to come back. I don't know what Dr. Yamane's views are for parallel wire.
One size smaller.
One- So it is quite a...
So this is now you're with a Corsair or a Caravel here now?
Caravel.
Caravel 150, and
We're taking
probably you can see that the distal target is not so much bigger vessel, which ideal for the ADR or the parallel wire. So that's why we switch earlier for the retrograde. As you can see that the some of them is connected, hint of the connection. So we need a more proximal injection. Wire. Yeah, but I mean, if you don't have a skill set for the retrograde and then you stick to the antigrade and the parallel wire, it doesn't make sense because if you do the CTO, you have to have a balanced experience with the either antigrade or retrograde. So probably for the practical point is probably you have every skill set for undergoing revascularization, I guess.
And that's why we have courses like this.
Yeah, exactly.
So do you have a septal in mind or you're going to be surfing?
No. I try to advance the guide wire into the distal.
So we're trying to
PDA.
do a selective injection in the distal RCA
Okay.
to look at the various
Could you go to
collaterals.
the areocranial?
And there are 2 or 3 septals there, so we just want to get some idea before
Areocranial,
we...
yeah.
So it's not really surfing, it's we're trying to take a picture. Yes, so you can see there are a few septals coming further distal down.
Okay.
So Sudhir, what are the considerations for the sake of the audience as to what we would, which septal you would like to take as your interventional collateral?
Well, so in terms of interventional collateral, there is a lot of, means there is some literature saying that which collaterals are successfully carried out. So it should be visible. Sometimes the visibility is good and less tortuous, relatively straight. And you can see a direct connection between the donor and the occluded vessel. Sometimes that is helpful. and you have to identify the collateral which is further down the distal cap. Because sometimes if it goes very close to the distal cap, then you might not be able to advance into the distal cap.
So
those are the
Sudhir,
kind of-
I'll have to interrupt you because we are now have to go back to Mumbai.
Okay.
You work on this and we'll get back to you.
Okay, okay,
sure.
thank you.
Dr. Sudhir, we are back with you. Whether you crossed with
Yes.
the retrograde wire?
No, he's...
Well, yes, so we are trying, so we did some selective shots and identified some septal collaterals. And we tried with, so obviously as we were discussing again how to choose the collateral channel. So broadly speaking, there are two components. First, to enter into a right collateral channel from a donor vessel, that is sometimes very challenging from the right coronary artery. So we entered in one of the collateral channels we thought is connecting to the distal LAD. And then changed it to SUO03. But we were having difficulty in crossing into the distal LAD with SUO03. And now Professor Yamane, as you can see here, very nicely has demonstrated, we changed the SUO03 to Sion black. And with Sion black, we are able to, it looks like, advance it into the distal left ventricular descending coronary artery. So do the, which, right? So we just do a injection to just check where we are.
A little bit different, huh?
Yeah, a little bit looks, so we take a picture from the left side,
Left side, yeah.
so from the diagonal connection.
No, you don't need the left side, yeah. It's different.
So it is different, it's not a,
It's
gone
not, it is not
was
connecting to the LED.
It was
no.
Now the problem is that this LAD collateral is very much fragile, so even the SO03 does not have a good alignment for the distal LAD, and this is also the different, yeah?
I think there
So-
is a lot of water to drink, but nothing to drink, nor a drop to drink. Lot of water, but not a drop to drink.
Right, so probably this is not a good one, so we try to go to the other one, and more distal one would be more straighter, I guess.
I think you have
So,
to go a
uh,
little more proximal. I think there is some proximal.
Yeah, maybe at this point, another injection will be of help, so, yeah, please. Keep this wire, yeah, this. Although septal surfing is also possible, but usually surfing is best for the LAD to the RCA direction, because,
Galassi can join us.
yeah,
Dr.
as
Galassi.
Sudhir mentioned, probably complex cases, probably,
maybe
yeah.
Maybe a one proximal one might have a better connection,
Yes.
which
Yeah,
bifurcates,
sure,
Yes,
sure,
yes.
which has got like a little bifurcating.
Sure, black, yeah, sure.
Just next to the tip of your microcatheter.
Yeah.
Just
Yes.
next to the, yes.
And I think we have seen again and again that if there are multiple collaterals, like if there is a leash of collaterals, it's always difficult to get into the right collateral as compared to a dominant single collateral which is supplying the distal vessel.
Yeah,
And
exactly.
sometimes it's easier course for that. When there are multiple,
Sudhir,
they are always small.
There is a
and
large collateral coming up there with a small multiple branches there. I think that is one collateral which some connection is there, I
Yes.
think.
Yep.
Yes, that's what we are trying to go for now.
You are taking which wire now?
So we have got Sion black.
Okay.
Still shown black, yep. Just enter into the branch, and if we get into,
Dr. Yamane, will you take any time for entry to the septic collaterals? Will you take a SUHO 3 wire or not?
so 3, yeah.
For entry to the vessel. I think
So
again-
we've now been joined on the dais by
Alfredo
Alfredo Galassi from Catania, and who does a lot of retrograde interventions also. He's had a very tiring flight. We met him in the morning after
Could you go
a
to
long
the
flight.
area?
So welcome,
Area.
Dr. Galassi.
Thank you very much, and very kind for
Well,
this
this
kind
is,
invitation.
different,
Thank
yeah.
you.
Epicardial, yeah.
Good morning, Freddie. Hope you're not jet lagged.
No,
A
he's
little bit.
jet lagged.
Okay.
He's a rock star. He travels all over the
Yeah, I
world.
know. He was in Russia last
Yeah,
week
so-
and
so
in other places. His travel schedule is. So we're trying to get into the
Yeah.
Give
septal
us a
collateral.
Sion wire, Sion black. Yeah. Sion black is too agile, so probably Sion wire.
So we take a
regular
Sion
wire,
wire.
yeah.
Yeah, so as Pratap mentioned, obviously there are two major steps. First, most important step is to get into the collateral channel from the right coronary artery, that is a sharp angle, and there is some data that if the angle is very sharp, like more than, it's like a retroverted angle, it is sometimes difficult to gain access. As you can see in the LAO view, what Dr. Yamane is trying to see is sometimes you can go into a epicardial channel which goes from the PDA into the different directions. So we have to come towards the septum, and it's good to go in the LAO view to see if you're getting into the septal area and then change to
So we have a comment from Dr. Hazra.
Yes. Yes, so see that here? So this is more like septal, septal direction.
Before. An angiogram analysis to be done before. I think the angle between the major branch to the septal, whether it is exit or entry point, that is a critical point of success.
Okay, go to the
And if this angle is less than 90 degrees, if you see angle, if it is more than 90 degrees, it's easier to get into that collateral channel. And if the angle of origin is retroverted, or it is less than 90 degree, or like 40, 45 degree, it's coming back on itself. Sometimes it is difficult to gain access, so you need a different wires, different bending to get into the thread, and then you get your microcatheter up, and then you change into some different wire with a very short tape, depending
Angle
on...
continuity size.
Yes, of course, yes.
Give us a
See this here?
Yeah,
So we have entered the collateral, and the macrocatheter
So the
is followed.
question that has been asked is, what is the role of CT angiography in determining the collateral which is to be chosen for a retrograde entry? Dr. Galassi, would you like to take that question?
CT is analysis of the collaterals.
Well, I think that CT scan is a very important tool, especially in very long CTO segment, and especially
yeah.
when you don't know
Are you happy with it?
the
New
vessel
one, new.
course. I think that
Fine,
that
nice.
situation, I think it would be really
No, but in
interesting.
choosing the
Yeah,
collateral,
new one.
not in choosing the choosing the method or in choosing the deciding the strategy, but in choosing the collateral which you're going to take. Does a CT help?
No,
Will we be able to identify? Dr. Werner has done a lot of work.
No.
I've seen a lot of his publications. Dr.
I
Werner,
don't
sir?
think so. I don't think so.
I
don't
think
know.
the CT
I
doesn't
no
have that kind
idea
of
if this
resolution.
may help.
The CT will not have that because the septal collaterals are usually like 0.4 millimeter in diameter if they are good collateral, even smaller. And the CT angiogram might not be able to tease out, obviously. I don't know, Professor Werner will be able to comment on this. I have not seen any data on CT helping in identifying the septal collateral. I think it's more about angio data is there.
But there is a report that once you visualize the collaterals, especially the septal epicardial, it's easier to cross with the guide wire. That is a retrospective. Number is 40 or 50, limited. But still, if you see the visualized collaterals on the CT, probably there's a good chance that you can pass it with the guide wire. That is a report. No, it's very strange direction. It's not the one. So we go to the little bit more distal one, and we.
So we all know
So
that.
Sudhir, you're absolutely right. Dr. Werner has the same opinion that you have no data suggesting that CT can help you to find out.
And
the
we all know that
collaterals.
collaterals are classified by Dr. Werner's name. So I guess that is a lot of experience telling us. So this is, and it is for this reason that we possibly
this is the septum.
did advocate doing a parallel wire technique at the time that we, because one can get, of course here we are with a master, and even he's having difficulty in getting retrograde. So we have in about a minute and a half till we revert to the other lab.
Sudhir, actually, you did a tip injection or not?
We have not done a tip injection yet.
Okay.
But obviously that is on our mind, and we might do it. We're just trying to see if we can go through different collaterals, do the tip injection and see if there's any
No.
better collateral. That's
Sudhir, is there any contraindication to doing a trip injection? Because these collaterals appear to be very small and they're very fragile. They appear to be quite
I
small in
think,
this case.
Yes, obviously we have to do it very proximal. So we are not sure that we have
Now,
entered.
did you switch over to SUO 3 or not? That is the question.
Yeah, this is SUO 03.
SUO 3 already.
So this is SUO 03 now, after entering into our collateral channel, which looks like a bit quite distal one, which is not, which is obviously from angiographic definition. it is CC0 or maybe something like that.
Sudhir, can we go to the other lab and
Yes.
take the final shot and come back for you? Another,
Yes.
you'll be
Then we-
getting,
then we
you'll
can
be
spend
getting
time.
only 5 to 7 minutes more.
Okay, if
We'll
you-
come back in 5
Yeah,
minutes
come
time,
back
but you
and
get
then
another
we-
7 minutes.
Okay, come back as.
Sudhir, we are back with you.
Okay,
Sudhir,
so yes, so in
you
the-
actually
Oh,
crossed.
you've done it, you've
Just
done it.
please
So
show
you-
us steps.
Okay, so if you go back to few frames,
Very angulated septal, huh?
yeah, so we've entered the same septal.
No, no, different
different
septum.
septal, yeah.
Different
But
septal difference.
Slaughter 3 did not have more supportive power. Next. 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 So in those cases, if SUO does not have a good support, and then
Okay.
either you can change to the more stiffer one, that is Sion black, it's okay in the septal, or that you can step down with the XDR,
Yes.
it's again okay with the septal. So you can see that this is Sion black, and this is very slippery and find a way, a little bit strange direction. But since we don't
It's a
see
double S
any
curve,
proximal, yes, and then slide into the proximal. So that's okay, yeah.
So you entered the septal collateral by using a SUO3 wire. After that, you changed the wire to cyan black, and cyan black helped you to take it into the LED, right?
Exactly,
Yes.
exactly. Are you agreeing?
So
Are you
Sean Black is the new fielder FC because it can take a lot of curves and it can,
Right side,
it is.
right side.
Right?
So now you are going
So
to
we've
cross the
done that,
CTO.
so we're just doing a live retrograde shot. You can see this here now,
Very nice, yeah.
very nicely there, and we are all set up for,
But it is looking like a very, very small channel.
yes,
Very
it is
small
a very
channel,
small
you know.
channel, which was not visible on the angiography, actually.
Do you,
Vessels
do you have
negatively.
Caravel as a microcatheter?
Caravel, yes,
Yes, yes,
Galassi.
it is, it is.
So now we're trying to advance the Caravel onto this wire. That will be
It's going
another
to be a
challenge.
challenge to get the caravel up.
Challenge because it's very distal, and usually Caravel is very elastic, and then to push the Caravel through this small channel distal will be very hard work.
Will you change the caravel to another microcatheter now? If the caravel is not
No,
crossing?
we are still trying, yes, of course, that could
Don't
be
be
an option, but we are
pessimistic.
still,
Don't be
we are
pessimistic.
still trying, and you can see it is making
Good
some
ends,
progress.
everything can
No,
be
because we have
possible.
only 4 minutes left out. You want to know a lot of things.
Which is another
Luckily, we
choice.
are crossing.
Wow.
We
Wow.
are crossing. Wonderful.
That's brilliant.
Brilliant. Even the wire also goes to
Crossing,
the.
yeah.
No, this is
CTO
Caravel
segment.
and
Your
Ah,
wire's
now
got
it
done a
is
direct
okay.
wire
we can
crossing.
go through anywhere.
No, no,
Anyway.
wire is not crossed. Wire crossed into
Including
the
our-
Yeah,
septum.
because the integrated wire is subintimal, so you can see the more the true lumen now, where
Yeah.
the true lumen stands.
Probably.
So I think we are well set up for,
Eh?
It's a direct wire crossing there. We'll see.
Okay, I think
maybe
this
see-
is deep enough, yeah.
yeah, I think so, yeah, deep enough. Looks like Sion Black is very close, but I think we
Will you change the wire or will you do a
Yes.
reverse cut and go that? Will you change the wire or will you do a reverse cut and go?
I think, as I know, Dr. Yamane, obviously, he will be the best. I think he will try to go for a contemporary reverse cart here, or contemporary, maybe, I don't know, he will change the wire.
Yeah,
One.
we change the wire to the probably guy next first.
Guy next
So
first,
will
yeah.
you change over to Gaia second or Gaia third?
No, guy next
Guy-
two.
Gaia next.
Guy next one.
One.
Guy next first.
Yeah.
Gaia
quick,
next
yeah.
first.
So we've got,
2 grams.
2 grams. 2 grams tip load.
yeah.
Not available in India. Gaia next still.
Bag of tricks.
No in Europe, no in the
No,
US.
in Europe, so yeah,
Not
for me
only
also.
Europe.
What would be your wire of choice here? in
Ultimate Bros 3. Sometimes
Ultimate
is
Bros
the
3,
most,
yes, we said.
He would use a UB3.
UB3.
Yeah, UB3 or Gaia 1 next, or Gaia 2 is a good choice here.
This is because especially when there are a lot of calcification, I prefer rather than to use Gaia, standard Gaia, to use UB3 because Gaia sometimes may be
Yeah,
disrupted.
the trapping of Gaia.
And
is
then
a
it's
phenomenon.
very difficult to pull
Yes,
back.
especially with the tough
What we do
operators.
need-
The Gaia will be broken
Zoom,
in
yeah,
sections.
mega.
We are not tough.
Yes.
1
yes.
mega,
Will
please.
not be.
And then it's a mess to pull it up because then it's going to all the way through to the retrograde. You will never be able to
Yeah, yeah.
take it out.
So we
So
are
this is the reason why I'm always
You know,
using
we-
Ultimate Bros until
You
I don't
really
have
shown us.
Gaia Next.
No, no, let him cross.
Yeah, let him
Let him
cross.
cross the CTO. We are waiting for you to cross the CTO segment.
Change the view.
This is which wire?
This is Gaia,
Gaia
one
next first.
Gaia Next first, yes.
Okay.
Antigrade is what? Gaia Next.
Antigrade is XTR.
XTR.
Yeah, we de-escalated. Well, it looks like antigrade wire might be in the true lumen now.
And the wire is crossed.
Yeah, I think your anti-grade wire is crossed.
No, no.
Yes, sometimes in my experience also, and in most of you guys who do a lot of CTOs, is that if due to some reason microcatheter can't cross retrogradely, many times the kissing wire is very successful. So you can always change the strategy, but here there are multiple options now. We have got the microcatheter.
Okay,
deep into
Sudhir,
the-
one comment from the audience. Sir,
Yeah.
please.
Try to do the rendezvous in a short time. Okay.
Yeah, yeah.
Could you give me a Gaia second? Gaia Next two.
We've done.
It
Gaia
straightens the
second.
vessel, dislodges the calcium a little bit, and you can.
Gaia Next two on the table.
Gaia Next two
no,
we have
Gaia
got
Next
here.
three. Sorry.
Three, yeah?
Sudhir, we have to go to the other lab, and if you can, okay, I think we are crossing the.
Yeah, so what we are trying to do, because of short time, Professor Yamane suggested that we do a rendezvous, try to get the antigrade wire into the microcatheter retrograde with a stiff
but,
wire. That's
just
not
a
an
couple
easy thing.
minutes. Yeah.
Or maybe just do like a kissing wheel, go into the, so that is the option, otherwise, see.
Okay. Yeah.
So-
So Gaia Next three.
So we've got Gaia Next 3 here, you're trying Gaia Next 3 antigradely to get into the collateral into the retrograde microcatheter.
So, Sudhir, we will go to the next lab and see
Yes.
the last shot and come back
Sure,
for
yes,
you for
please.
2 minutes.
Yes, thank you.
We will go to the
show
lab
me
and
the
come
upper
back in
portion.
2 minutes. Dr. Sudhir, we are back with you.
Yeah, well, as you can see here, Dr. Yamane is trying very elegantly to do the rendezvous because both microcatheter, antigrade and retrograde are very close to each other. But
You are
as you
actually
can
doing
see-
a parallel wire, one wire retrograde, one wire antigrade
No,
parallel
no.
wires.
Right
No,
now
no,
he's doing
trying
a
to get into that
microcatheter
microcatheter.
rendezvous.
So microcatheter rendezvous, but I think we have to maybe resort to a reverse cart of some kind.
Maybe that is better. Yeah.
Yeah, reverse-
Aleocranial. Yeah.
Aleocranial, please. See that there is a space, so I think it is deceiving in one view, so it's always a good idea to take another view.
Yeah. Yeah. That's a very good point.
And it's a good learning.
So you'll have to keep switching the views because you need 2 orthogonal projections to see where.
Come table this side.
We have only 2 minutes satellite transmission left out. 2 minutes, he's telling exhausted, but we just half a minute, you can finish it off.
So Pratap is using his course director prerogative to extend this.
Oh, thank you. Yeah, so I think we'll do that. And if it is, obviously the step from here is, if it doesn't work, we'll do a reverse cart of some kind.
We want to see his
Yeah.
crossing the lesion. I think
I think we'll do a reverse cart.
I think
Reverse card.
Yeah, I think so. I think that wire is in a good position, antigrade. I think we will try a reverse cart. We will exchange that microcatheter, put a balloon there, and take a wire.
Okay. 2 minutes has passed.
two-
Since you can see that the antigrade and retrograde is already
In the same.
quite
Oh, yes,
overlapping.
yes.
So we do the reverse card, just classic, and then we finish.
Yes.
So
although
what
we
what kind of
cannot
reverse card do
finish.
you want to do?
directed reverse
guideliner
cart,
reverse
directed reverse cart is the
Maybe
best.
guideliner reverse cut, I explained, would be the safer in terms of the not to cause the injury of
proximal,
the, potential injury of the proximal. Go to the REO, yeah, please.
actually all the best for Dr. Yamane and the team, and we are just winding up because of the time is finished.
Sure.
Thank
sure.
you very much. Excellent
Thank you very
demonstration.
much.
Thank
Great
you very much,
demonstration of a very good,
chairpersons,
very difficult
members
retrograde.
of the expert panel, and the operators at SGPGI and Dr. Hiranandani.